Today's speaker is Dr. Donna Zolman, who is an assistant professor in the Division of Primary Care and Population Health at Stanford University School of Medicine, and associate director of the Center for Innovation to Implementation at VA Palo Alto Healthcare System. Today, Dr. Zolman will be presenting Fostering Physician Humanism and Connection with Patients. Welcome, Dr. Zolman. It's a pleasure to have you join us today. I'm going to go ahead and pass our virtual microphone over to you.
I am delighted to have this opportunity to present our project today entitled Presence 5, Fostering Physician Humanism and Connection with Patients. I'd like to acknowledge my wonderful partner and collaborator in this work, Dr. Abraham Verghese, a physician and author who has inspired many of us through his writing and his work in bedside medicine and the clinical exam. This quote comes from one of Dr. Verghese's articles and is really at the heart of the project I will be sharing today. Even though medicine changes, the fundamental role of the physician, the need for their presence, does not change. Cure is laudable, but not always something we achieve. But comforting and healing is something we do. The Presence 5 project grew out of observations that time constraints and administrative demands of modern medicine often impede the human connection that is central to clinical care. Yet busy clinicians are wary of implementing one more thing. So our objective for this project was to develop a simple, scalable, evidence-based intervention that fosters physician humanism and patient connection. Our team spent close to 2 years doing formative research into evidence-based strategies that would foster meaningful connection with patients. This included a systematic review of evidence-based interpersonal interventions from the medical and social sciences literature, observations of clinician-patient interactions, and interviews with clinicians and patients at 3 diverse primary care clinics, interviews with non-medical professionals whose work involves intense interpersonal interactions, a human-centered design method for learning from analogous experiences, and then finally, to synthesize the evidence, we conducted a modified Delphi panel with physicians, researchers, and patient and caregiver advocates to quantify expert opinion about our findings. The goals of these steps were to identify a set of practices, specific actions that clinicians can take that foster physician presence and connection with patients. For the systematic literature review, we included randomized controlled trials and controlled observational studies that focused on a doctor-patient interpersonal intervention, which we defined as a selective systemic process that allows people to reflect and build personal knowledge of one another and create shared meanings. The study also needed to evaluate at least one outcome from the quadruple aim of health outcomes, patient experience, provider experience, and cost. We started with 21,835 abstracts and ended up with 73 studies in our full review. We found through this process a number of interpersonal interventions and trainings for physicians that can have a positive impact on patient experience and can improve provider well-being, burnout, stress, and confidence communicating with patients. Cost and proxies for cost, such as utilization and prescription rates, were evaluated in a minority of studies. Importantly, among studies with positive outcomes, interventions rarely increased visit lengths, and we also found that interventions with low or moderate demand on provider time and effort were as effective as higher demand interventions. As part of our formative research, we also reviewed previous doctor-patient communication training materials, including interventions focused on primary care, narrative medicine, cancer care, and thriving in a busy practice. So I just want to mention that we recognize that we were standing on the shoulders of giants with this project. Many wise clinicians have thought deeply about this topic, and our goal wasn't to reinvent the wheel, but to identify the core practices that are really central to this idea of human connection. The second component of our formative research involved clinical observations at 3 primary care clinics, including an academic medical center, a VA general medicine clinic, and a federally qualified health center primary care clinic. We observed and recorded 27 encounters and interviewed 10 physicians and 27 patients. We used a rapid ethnographic approach to identify promising practices that appear to facilitate clinician presence and patient connection. These findings helped augment what we learned from the literature review and offered concrete examples that helped inform intervention design. Finally, a third component of our formative research involves interviews with non-medical professionals who have intense interpersonal interactions in their work and for whom presence and connection are central. This work was inspired by human-centered design methods, and our 30 interviewees represented diverse professions, including a firefighter, police officer, chaplain, social worker, teacher, and documentary filmmaker. During these interviews, we explored practices that establish trust and boundaries and foster interpersonal connection. To give you a flavor of what we learned from these individuals about the concept of presence, we heard things like staying focused on the moment, looking somebody in the eye, listening and responding to them. This was from a journalist. Most of the time, it's about hearing someone's story and about why they did something and where it led them and who they are now. It's from a documentary filmmaker. And I use the mantra, now, here, this. When I remember to do that, it has been helpful. And that was from a restorative justice lawyer. After completing the literature review, clinical observations, and interviews with non-medical professionals, we turned to evidence synthesis. Based on our formative research, we converged on a definition of presence, which is a purposeful practice of awareness, focus, and attention with the intent to understand and connect with patients. We then generated a list of potential practices that contribute to clinician presence and connections with patients. For each practice, we examined supporting and contradictory evidence from each of our research steps. Then, once we had a refined list of practices, we conducted a targeted literature review of each practice with evidence from diverse fields, for example, medicine, sociology, psychology, business, and education. And finally, we generated an evidence brief for each practice to review with experts. The modified Delphi panel included 14 physicians, researchers, patients, caregivers, and health system leaders. We asked experts to rate each preliminary practice on 3 criteria: the potential impact on patient experience, the potential impact on clinician experience, and implementation feasibility. We also asked for their qualitative feedback. This figure represents a snapshot of the process. Our formative research steps yielded 31 preliminary practices, and after a few iterations and additional literature review, we presented 13 practices with supporting evidence to the Delphi panel. The experts did 3 rounds of review with quantitative and qualitative feedback, and we ended up with 5 practices, the Presence 5. Here is a more complete illustration of the Presence 5 practices: prepare with intention, listen intently and completely, agree on what matters most, connect with your patient's story, and explore emotional cues. The practices are presented in detail in our 2020 paper published in JAMA, and I want to spend a few minutes now sharing a bit more detail about the goal of each practice and some examples of specific strategies that clinicians can use. The first practice is prepare with intention. This is about familiarizing yourself with the patient you are about to meet and creating a ritual to focus your attention before a visit. Physicians are often rushed, seeing patients in back-to-back visits, and it can be valuable to take a moment to pause and focus your attention between encounters. A specific strategy that can be helpful is to perform a brief chart review, emphasizing key elements of the social history to remind yourself of the person you are about to see. Another strategy is to create a ritual out of a routine practice. For example, as you're entering a room, put your hand on the doorknob and take a deep breath, or take a moment to focus during hand washing, maybe even using a mantra. We heard from one clinician that they begin each visit with the mantra, "Let me help this person be as healthy as possible." The second practice is listen intently and completely. The goal of this practice is to position oneself to fully hear a patient's story and perspective. Sit down, lean forward, position yourself to listen, recognizing that your patient is your most valuable source of information. This is a practice that is supported by a wealth of evidence. When it comes to nonverbal communication, thoughtful body positioning has been shown to support relationship building, trust, and patient satisfaction with treatment. Specific strategies here are to sit down and lean toward the patient, maintain an open body position, and if you need to be seated at a computer, position your body towards the patient as much as possible, and avoid interrupting a patient during their opening description of health issues. In combination, these actions can increase the amount of time that the patient perceives having spent in the consultation and can lead to patients communicating more, providing more medical information, and reporting greater satisfaction with the visit. The third practice is agree on what matters most. This practice is about finding out what your patient cares about and what are their goals, what's most important to them, and incorporating these priorities into the visit agenda. A simple form of this practice involves beginning the visit with an open-ended question like, what would you like to discuss today? Or, what brings you here today? Then develop an agenda that incorporates the patient's priorities. At the end of the visit, you want to review the agenda and elicit any unaddressed priorities. Interestingly, one study found that using the word, is there something else you want to discuss today, is more effective at eliciting unaddressed concerns than the question, is there anything else you want to discuss today? And evidence suggests that collaborative agenda setting reduces last-minute concerns, improves patient satisfaction ratings, and can positively influence symptoms such as pain and anxiety. The fourth practice is connect with your patient's story. This practice is all about considering the social, cultural, behavioral circumstances that influence your patient's health, and also finding positive connections, acknowledging your patient's efforts, and celebrating success. The first step is to be curious about your patient's life story. This not only draws out important information that can guide your clinical care, but this mindset also can help you interrogate potential biases that you might have. Some clinicians try to identify a shared experience with each of their patients. One of the clinicians we work with said that he likes to ask patients, what brings you joy? Maybe you're both parents or you enjoy the same hobby, and spend a moment talking about that. Use positive language, including statements of approval, reassurance, and partnership. And offer the patient genuine and honest praise for their efforts, acknowledging success when appropriate. Physician positivity has long been associated with positive patient health outcomes. Acknowledging patient efforts and progress has a positive effect on patient adherence and encourages patients to be more active participants in their care. The fifth and final practice is explore emotional cues. Tune in, notice, name, and validate your patient's emotions to become a trusted partner. There is so much we can learn from tuning into a patient's verbal and nonverbal emotional cues, such as changes in tone of voice, facial expressions, and body language. One of our collaborators for this project talked about how she considers the patient's face to be a roadmap of emotion. Ask your patient how they are feeling about their health concerns and stressors, and reflect, validate, and confirm your perceptions of a patient's emotions. So here again are the Presence 5 practices. They are intuitive to many clinicians, representing what is at the core of medical care and healing. But in the context of today's busy medical practice, with its endless distractions, adopting a ritual to explicitly focus on presence and connection can help build trusting relationships and can have a positive impact not only on the patient, but on the clinician as well. After identifying the Presence 5 practices, our work wasn't done, as we felt it was important to not only determine the content of the practices, but to think about how to best deliver this information to busy clinicians. During this next phase, we worked with colleagues who have expertise in human-centered design to develop a prototype for a Presence 5 intervention that is feasible to adopt and sustain within a busy clinical practice setting. This phase involved mapping the journey of physicians to understand how they might integrate Presence 5 into their clinical encounters, co-creation sessions and user feedback sessions with clinicians, and piloting of some of our prototypes with clinicians and staff in primary care clinics. One of the outcomes of this work was the concept of a presence circle, a 1-hour peer-moderated discussion group that provides an opportunity for clinicians to share how they use the practices in their own clinical settings. We have now workshopped these circles at several national and international conferences and distributed materials for facilitating presence circles to a number of institutions around the world. Before I close, I wanted to mention some directions that this work has taken over the past year. Shortly after we published the Presence 5 practices, the world was turned completely upside down by the COVID-19 pandemic. Early in the pandemic, the most critical priority was to ensure that our local healthcare systems were prepared for a possible surge. But as the situation stabilized a bit, one thing that became clear was that the pandemic was spurring a major shift from in-person care to virtual care, and many clinicians were practicing telemedicine for the first time. So our team started to explore how the practices we had identified through the Presence 5 project could be adapted to telemedicine. We returned to the literature, reviewing articles and guidelines about telemedicine, and worked with clinicians to identify telemedicine practices that map to the Presence 5 domains. We then developed a number of resources, all of which are available on our project website and were published online by one of our team members, Dr. Megha Shankar. The Telepresence 5 practices align with the original domains, but now focus on strategies that are helpful for connecting with patients during virtual visits. For example, to listen intently and completely, it can be helpful to maintain eye contact by looking at the camera, and you might need to use more exaggerated facial expressions and gestures to communicate empathy. And interestingly, even though virtual visits present certain challenges, in some ways they are an invitation into our patients' homes, and so they can present an opportunity to connect with our patients' stories in a new way by learning more about their home environment and social support. Another adaptation of Presence 5 that is in progress is the development of an intervention for medical trainees, and we are fortunate to be working with colleagues from Johns Hopkins, Stanford, and University of Alabama to implement and evaluate Presence 5 interventions for internal medicine residents, supported by an AMA Reimagining Residency grant. A third adaptation of Presence 5 grew out of a response to acts of racial injustice over this past year, as well as racial health disparities that were magnified by the COVID-19 pandemic. In this project, we are adapting the Presence 5 to promote anti-racist dialogue among clinicians and to identify practices that build trust among Black patients and promote health equity. For the Presence for Racial Justice project, we are incredibly fortunate to be partnering with 4 diverse primary care and community clinics that serve predominantly Black patients: Roots Community Health Center in Oakland, California, University of Alabama Medicine Clinic in Leeds, Alabama, Church Health in Memphis, Tennessee, and Culver Medical Group in Rochester, New York. We formed a community advisory board that includes patients and clinicians from each of these sites, and we have been meeting with them regularly to guide our research. And we are just now wrapping up several months of interviews with patients and focus groups with clinicians. Through this work, we have identified practices that clinicians can use to disrupt racism and promote health equity, and we are now mapping those practices to the Presence 5 framework. So here, for example, under Prepare with Intention, we talk about considering how your identity, including your race, gender, and socioeconomic status, could influence how you perceive the patient and how the patient might perceive you. We talk about listening for your patient's experiences with racism, bias, and mistreatment, considering how a patient's story might be influenced by historical instances of racism and structural racism. And under Explore Emotional Cues, we encourage clinicians to consider how racial trauma might influence a patient's emotions. And we are currently building on the Presence for Racial Justice project to develop a curriculum for medical students that fosters anti-racist dialogue among students, teaches strategies to reflect on personal biases and historical racism, encourages advocacy for Black patients, and promotes racial justice during clinical training. So our journey with this project continues. Throughout, we have leveraged human-centered design principles to develop simple interventions, drawing on evidence when possible to foster physician humanism and connection with patients. We have several adaptations that are at different stages of development and evaluation that highlight opportunities to connect with patients during telemedicine encounters and to address systemic racism and health equity in clinical care. And across all of these projects, we seek to draw on multiple disciplines to develop interventions that are accessible, easy to implement, and transformative to clinical practice. More information about this project and our publications can be found at this website link on the slide. And I want to thank the amazing team of researchers, clinicians, students and trainees, staff, advisors, and expert reviewers who have contributed to this work. I also want to acknowledge our research grants and the generosity of donors who have supported this work. And here's a photo of our team on Zoom. Thank you very much.
Thank you, Dr. Zolman. After these next few slides, we will transition to the Q&A. For additional resources to support your physicians and staff during this time, please visit the American Medical Association website. We thank you for your time today and hope that you're able to join our next webinar, which is scheduled for tomorrow, April 21st at 12 p.m. Central Time. Tomorrow's webinar will feature Dr. Marie Brown, who will be presenting on taming the EHR. For general questions or comments, please email the Steps Forward inbox at stepsforward@ama-assn.org. With that all said, let's go ahead and jump into the live Q&A.
Thank you again for being here with us today. To our participants, thank you so much. We already have several questions in the queue, so I'm going to jump right in. But before I do so, to our participants, if there's a question that you would like to elaborate on, we do encourage you to use the raise your hand feature. We can unmute you from the back end so that you can elaborate on your question verbally. Otherwise, go ahead and submit it through the Q&A. For any questions, as I said before, that we're unable to answer, please email them to the Steps Forward inbox. So with that said, I think we could go ahead and jump in, Dr. Zolman. We do have several questions in here. All of them look important, so I'm going to sort them out. You mentioned that there are many benefits to using the Presence 5 practices for both the patient and the physician. So this participant wants to know if you could elaborate more on the benefits for the physician specifically.
Yeah, I think the biggest benefit for physicians is that these practices can help clinicians connect with what many of us find most meaningful about medicine, and that's this opportunity to be present with and for another human being during some of the most intense and personal moments of their journey through life. Through these practices, we've tried to offer simple, concrete strategies that are evidence-based and that other clinicians find valuable. There are other potential benefits that we identified in our evidence review. For example, one large systematic review of studies of mindfulness interventions found that these steps of being mindful can have a positive impact on clinician anxiety, depression, and stress, as well as on clinician experiences with difficult visits. And one question we often get is whether these practices will lengthen the time of a visit, given that physicians, especially in the primary care context, are already so stretched for time. And so just to address that, in our systematic review, we specifically examined this question, and among the 11 studies that measured visit time, most found that communication practices, including listening without interrupting, improve patient and provider experience without significantly increasing visit time. And one reason for this is that the visits are more efficient and that patients are more likely to discuss their concerns and priorities early on. And you're less likely to end up with what's sometimes called a doorknob moment, where you're about to leave the room and the patient says, oh, by the way, doc, I wanted to mention something or get your take on some critical issue that needs evaluation. So overall, the evidence suggests that the practices can help clinicians have more meaningful interactions with their patients and can improve their own experiences delivering care without extending visit time or creating additional burdens.
Great, thank you. And do you feel that people who are utilizing these practices more often, decrease the amount of time that they're spending with the patients? Then, so in the beginning, as you're learning to implement the Presence 5 practices, it might be hard to remember, but as you advance your skills, it will likely shorten the time.
Yeah, and I think maybe maybe not so much shortening the time as letting you use the time that you have for the more meaningful connection, and also to get the information that you need for diagnosis and treatment decisions without kind of additional time.
Right, thank you. So just as background knowledge, it looks like we have participants that are both from large health systems and small practices participating in today's session. So do you have any advice for both the small practice and the health system level as to how leadership can educate their physicians to utilize the Presence 5 practices?
Yeah, so in going through this project, our goal was always to create an intervention that could be implemented in a wide range of settings. And so part of the human-centered design work that we did was to try to create a way of disseminating this information to clinicians. And what we learned from our clinician workshops was that clinicians really like to learn from their colleagues. And so that's where this concept of a presence circle came from, where this is usually about a 1-hour discussion that's led often by somebody in your clinical setting with your colleagues in the clinic, where people can review these practices together and share the strategies that they find particularly useful. And this can be really helpful because you can hear what your colleagues working in a similar practice setting with similar patient population find to be most valuable. So we found that clinicians really like that way of learning. And on the Presence website, which I can put in the chat, we have a facilitator's guide for people who want to bring this curriculum back to their clinical setting or to their trainees.
I heard you in that discuss the element of teamness and you really learning to use these practices as a team, which translates to transitions us smoothly to our next question. This participant indicates that their practices utilizes the team-based care model. We talked a lot about how physicians can utilize these interventions. Do you think that they can also be adapted by others on the care team, such as MAs and PAs?
Yes, absolutely. So we've considered creating adaptations to the Presence 5 practices for specific team members, but the current practices are really very relevant across a wide range of providers. And I think one of the reasons for that is that the approach we used in the research was to collect information from a diverse field. So by interviewing all the non-medical professionals, by looking to the literature outside of medicine, our goal was to find these more universal strategies for interpersonal connection in stressful circumstances that could be applied to medicine. So I think that the practices are very accessible, and again, the resources that are available at the website include things like posters that can be put up in clinics, as well as the discussion guide that can be distributed to any providers in a clinical setting.
That's very helpful. Thank you. So this next question discusses potential barriers through implementation. Have you seen any barriers to implementing the Presence 5 practices, and how do you suggest that practices and physicians address potential challenges?
Yeah, it's a great question. I think that probably the biggest implementation barrier has to do with just human behavior and the fact that we all have the ways, communication practices that we've developed over time, and it can be really hard to change those. And so what we recommend through these presence circles is that people identify one practice that they want to try to adopt and set a goal. And actually at the end of the discussion, we have people kind of share their goal with the group, and then come back a week later and share how that's going and any barriers or challenges they've experienced so they can kind of troubleshoot together. So it's, we're not going to change all of our communication practices overnight, but the idea here is to kind of give a toolkit of potential strategies, and so that you can select the ones that feel comfortable and accessible to you and try them out.
That makes sense, Dr. Zolman. This next question is very important. This participant would like to know if you could talk a bit more on the element of trust, and if there are any specific practices that really hit on that element of trust. And I say this is important because, an important topic right now is the COVID-19 vaccine and potential conversations that physicians are having on vaccine hesitancy. So I think that element of trust is something that's very important through those conversations.
Yeah, I absolutely agree. Trust is essential, and it was a major focus of all of this work. And I would say that all of the practices in some way address the issue of trust, but particularly the practices around listening, letting patients share their story uninterrupted, trying to understand what's important to them, what their priorities are, and also understanding the emotions behind what they're expressing, their experiences with healthcare in the past, and what might be driving their decision making. So I think that listening, that really trying to tap into what's important to the patient, expressing that you want to find a path forward that aligns with their goals and priority. So I think those are the practices that are kind of most aligned with the trust domain.
That's good to know, right? Every patient is so different, so it's important to really listen in and hear those individual differences so you can address every patient in a unique manner. It looks like, Dr. Zolman, there are no further questions in the queue. If our participants do have follow-up questions, again, please feel free to submit them to our email. That's the steps forward at ama-assn.org. I think that will conclude our session for today then. Dr. Zolman, can't thank you enough for being here with us today. Your expertise is invaluable, and we so appreciate your time, especially during the current circumstances that we're all going through. And to our participants, thank you so much for joining us. We hope to see you all again soon in another webinar.